localized prostate cancer. It is called Stereotactic Ablative Radiotherapy. It's something that we've only offered for maybe about 4 years or so at the cancer clinic, and it's evolved quite a bit since then. So I wanted to give you a bit of an update about that. So here's the things I was going to talk about today. I was going to give you a brief overview of all the standard treatment options that are available for prostate cancer. And then I wanted to go into detail on what is this newer treatment, prostate stereotactic radiotherapy, and how does it differ from the normal radiotherapy that we've offered for 30, 40, 50 years. And I would like to go into a bit of detail on what the technology that we have that's involved with the delivery of this newer treatment, and go into a bit of the data that we have for this treatment in terms of the side effects, quality of life, and disease control. And then lastly, I close out with some of the new directions that we'd like to take this technology. So to start with, I mean, all of you know that prostate cancer is very common. In fact, it's the most common non-skin cancer in men. And unfortunately, in Canada, about 25,000 men are diagnosed with prostate cancer every year. That makes up about 20% of all new cancer diagnoses in men. So about 1 in 7 men are expected to develop a prostate cancer in their lifetime. It's also, unfortunately, the third most common cause of cancer death in men. Approximately 5,000 men die every year of prostate cancer, and that makes up about 10% of all cancer deaths in men. So it's a serious, large-scale problem. When we talk about prostate cancer, we divide it up into 2 general groups and how people can present with their cancer. Fortunately, about 70% of men who are diagnosed with prostate cancer are diagnosed with what we call localized prostate cancer. And so that's cancer that's localized just to the prostate gland, hasn't spread anywhere else. And so that means that it's potentially curable with treatments that are directed towards the prostate. Unfortunately, about 30% of men are diagnosed with metastatic prostate cancer at the get-go. And unfortunately, that's cancer that has spread beyond the prostate gland, usually to the lymph nodes or the bones. And unfortunately, it's not curable. It is, however, highly treatable. And as many of you are aware, hormone therapy is a mainstay of treatment of this, but in modern oncology, we now have a number of agents that we can add on top of that have really revolutionized quality of life and longevity for men with metastatic prostate cancer. But the bottom line is it's the localized prostate cancer that fortunately is the majority of what we see, and is also fortunately the cancers that are potentially curable. And so that's what I'm going to focus in on today. And so with the cancers that are potentially curable, the localized ones, in order to determine what the best treatment for somebody is, we divide them up by risk. How risky is someone's cancer? Because the level of risk someone's cancer has kind of dictates what the rational treatment options or management options for that cancer would be. And so this is kind of the theme that we use. We divide men with the curable cancers into, it's nice and easy, low risk, medium risk, and high risk. And we base these decisions or base these categories on how high someone's PSA is, the blood test, what the Gleason score is, and the Gleason score is a number that's associated with the biopsy that gives us an idea of how aggressive the cancer cells are under the microscope. And then the last thing we look at is stage, and that's kind of a rough measure of how much cancer someone has, where it's may or may not have spread to, that sort of thing. And when we combine all those 3 features together for an individual person's cancer, we can lump them into one of these 3 groups: low risk, medium risk, and high risk. And as the names of the would suggest, the higher the risk, the higher the probability of the cancer spreading on you, the higher the probability of cancer potentially leading to death at some point in time, and the more difficult it is to cure with our treatments. And so in 2023, fortunately, a large number of men are diagnosed with what we call low-risk prostate cancer. Those are the ones on the left side, where their PSA is low, their Gleason score is low, and their stage is low. And fortunately for those men, many of them were able to recommend surveillance rather than an active treatment. So many of these men are able to just sort of watch their cancer and not have an active treatment for it, because it's a very slow-growing cancer that may not ever harm them. The men with the intermediate and the high-risk cancers those are the kinds of cancers that we think are potentially a threat to somebody's life. And so those are the ones that we generally recommend active treatment for. And so for men with sort of the middle risk cancers, those are the cancers where that can be managed with surgery. They can have external beam radiation treatment. They can have brachytherapy, where we put radioactive seeds into the gland. And then when we go up to the next group, the high risk category, these are men with kind of more aggressive cancers, and the treatment options become a bit more involved. These are men who often, may still go for surgery, but many may require radiation treatment after surgery. There's a few different treatment options for the radiation, but they tend to be a bit more intensive, and we often combine them with medications, the hormone therapy. So there's sort of multiple modalities of treatment are often required in order to get good results and outcomes for men with high risk disease. So I just alluded to these, but these are the treatment options that we have today, the standard treatment options that we have today for localized, potentially curable prostate cancer. And so the first option is surgery. Men can have their prostate gland removed. The second option is the brachytherapy, where we put the radioactive seeds into the gland and kind of treat it from the inside out with radiation. The third option is what we call conventional external beam radiation treatment, and that's where we use an external radiation machine to kind of zap the prostate gland from the outside. And then the newest one, the one I'm going to focus on today, is the stereotactic ablative radiotherapy, which we call SABER for short. So I'm going to talk about regular conventional radiation treatment to kind of highlight, why we have kind of moved towards this newer treatment, the SABER, and what some of the deficiencies with the conventional treatment are that led to this. And so conventional external beam treatment, as I mentioned to you before, it's a very effective treatment for prostate cancer that uses high energy X-rays that are delivered from a linear accelerator, a radiation machine, to treat the prostate gland and sometimes the lymph nodes in the area of the prostate. The advantages of conventional external beam radiation treatment is it's non-invasive. It's the one treatment option that doesn't require any going to the OR, no needles, no cutting, nothing like that. It's completely non-invasive. It's also very well tolerated. The side effect profile of external beam radiotherapy is particularly with our technology today, is excellent. I mean, people tolerate it very, very well. It's also reasonably effective. Most men do very well following it in terms of disease control, and it's broadly eligible, or men are broadly eligible for it. And what I mean by that is almost everybody with prostate cancer would be a candidate for it, whereas that's not necessarily the case for, say, surgery or brachytherapy. To be eligible for surgery, you have to be someone who we think could tolerate going to the operating room, having a big operation, tolerating anesthetic. There's certain criterion for that. Similarly, for brachytherapy, there are other criteria that limit the eligibility. For example, the prostate gland can't be too big, or brachytherapy is not an option. Your bladder has to work reasonably well, or else you're not going to do well after brachytherapy. But the external treatments are basically almost all men these days, with few exceptions, are eligible for it. But it does have a few disadvantages. And the biggest disadvantage of the external treatments is it's a long course of treatment. As some of you are probably familiar with, courses of radiation treatment, external treatments for prostate cancer can range from anywhere from 4 weeks to 8 weeks of daily treatments Monday to Friday. When I started at the cancer clinic here in 2006, our standard treatment for prostate cancer was 39 radiation treatments delivered over 2 weeks, which is a huge time commitment for men, particularly difficult for men who don't live in Victoria. If you have someone who's coming to Victoria for treatment from Campbell River or Nanaimo or Powell River, that's a very difficult thing to do, is to be away from home for 2 weeks of treatment. So that was probably the biggest difficulty with it. I mean, nowadays it's not quite as long. Now the regular radiation treatment is about 4 weeks, but it's still a very significant time commitment. The other disadvantage is, and we're not entirely certain about it, but there is some data to suggest that the disease control with conventional radiation treatment may not be quite as good as the disease control with either surgery or brachytherapy. It may be a little bit less effective. And so, oops. Before I get into the issues of conventional external beam radiotherapy, I would like to point out that it's a great treatment. It is a really, really good treatment, but there are some issues with it, and that's why we sort of moved towards this newer treatment, this stereotactic treatment. So I'm going to point out some of the issues with it. There we go. So one issue with the regular radiation treatments is that the prostate gland moves. It's a weird thing to think about. When someone's lying on the table getting a radiation treatment, the prostate gland doesn't just sit in the same place still. And the prostate gland moves kind of front and back when you're and up and down when you breathe. It may move forward a bit if there's a lot of stool or gas in the rectum. It may move backwards and down a bit, depending on how full your bladder is. So the prostate gland's not always in the same place when someone's lying on a radiation treatment table to get their treatment. And that's important because radiation treatments can take 5, 6, 10 minutes. And if the prostate gland is moving, it will move out of the area where the radiation is and can result in missing dose in radiation missing parts of the prostate gland, which could decrease the effectiveness of the treatment, or could result in more radiation going to, say, the bladder or the bowels, causing higher side effects. And so this diagram kind of shows that. On this first on the left side, this is a CT scan that we use for planning radiation treatments. And you know, this pink circle here in the middle, that's the prostate gland. This yellow circle in front of it, that's the bladder. And this big blue circle behind it is the rectum, the bowel. And so we're trying to treat the prostate, this pink circle, but because it's moving around, we have to add a safety margin around it to make sure that we hit the target each day. So when we plan a regular radiation treatment, we actually, when we're trying to treat the prostate, this pink circle, we add a margin, that's this red circle around there. We actually plan to treat the red circle. And so the problem with that is, as you can see, the red circle overlaps quite substantially with the bladder, and it overlaps quite substantially with the rectum, the bowel. And so, and you can see this other diagram is just the same thing from the side. So the problem with that is we're giving a lot of radiation dose to organs nearby that we don't want to give radiation to. And so because of that, the bladder and the bowels, at least a portion of them, receive a fairly high dose of radiation. And in order to make that tolerable, in order to not cause a lot of side effects for somebody with the bladder and the bowels from the radiation, that's why we have to split the radiation dose up into a bunch of small doses. When we break the radiation dose up into a bunch of small doses, 20 or 38 or 39 treatments, then all those organs, the bladder and the bowels, and that's how we've gotten away with giving radiation treatments all these years. But the problem is, that's why these courses of treatment are so long. The other thing is, because our treatment necessarily treats a chunk of the bladder and a chunk of the rectum, we don't want to overdose those organs. We don't want to cause damage. And so because of that, that limits how much radiation we can give to the prostate gland itself. And in general, the more radiation we can give to the prostate gland, the better our disease control is. The more radiation we give, the more prostate cancer cells that we can kill with the radiation. But because we're limited by not wanting to damage the bladder or the rectum, we have to give a little bit less radiation, and that results in suboptimal disease control, lower cure rates than we could achieve if we were able to give more radiation to the prostate. And so in 2023, or over the last sort of 10, 15 years, we've had a number of improvements in our technology. And these improvements in technology have allowed us to sort of focus the radiation on the prostate better, so the radiation dose conforms more tightly to the prostate gland. And because of that, these technological advancements allows us to give less radiation dose to the bladder and the bowel. And when we do that, then we're able to start giving smaller number of treatments, but make each treatment bigger because we're not giving as much radiation to those organs. And then on top of that, it allows us to give a higher dose to the actual prostate gland itself so that we can improve disease control. And these are the principles behind this newer treatment, the stereotactic radiation treatment. But stereotactic radiation treatment is not the only option that use these principles. Brachytherapy, as I mentioned before, a treatment where we put radioactive seeds into the gland, also achieves all these principles. And these are just CAT scans showing someone who's had brachytherapy. You can see here all these little white dots are radioactive seeds that are placed in the gland. When we, with brachytherapy technology, when we put the radioactive seeds into the gland instead of firing from the outside, we're able to achieve those similar goals of having low doses of radiation to the bladder and the bowels, and we're able to give the radiation much quicker, often in one or two sessions. But the problem with brachytherapy is it's invasive. It's an invasive procedure. It requires going to the operating room. As I mentioned before, it's not appropriate for all patients. And with the brachytherapy, because there's a component of trauma where we use needles to put these seeds in the gland, that causes a lot of swelling of the prostate, which results in, for some men, quite a bit of side effects with the bladder in the first few months after treatment. So brachytherapy can achieve some of these goals, but has its own limitations. So a treatment option that has the effectiveness and the convenience of the brachytherapy, or surgery for that matter, but is non-invasive and well tolerated, like the regular external beam radiation treatment, that's something that would be desirable. That's something that would be, certainly a really good option for men. And that's what brings us to those newer treatments, SABER, stereotactic radiation treatment. And so what stereotactic radiation treatment is, in a nutshell, is just basically a form of the regular conventional external radiation treatments that I described to you before, but it uses some advanced technologies we have to more tightly focus the radiation, the high dose of the radiation to the prostate gland, and improves the accuracy and the precision of the radiation delivery. And because it's more accurate and more precise, it allows us to narrow out those safety margins I mentioned around the prostate gland, so you get less radiation dose to the organs nearby. You can get a higher effective dose of radiation to the prostate gland, so you can hopefully have better cure rates. And it also reduces the number of treatments that someone has to come in for. Instead of coming in for 20 or 38 treatments, we're able to get the treatments in. Usually we do 5 is what's done these days. So it's a huge time saver for men. And so this just shows how by adding a smaller safety margin around the prostate gland when we're treating it, now we're seeing there's much less, our safety margin here is much narrower than the slide I showed you before with the regular radiation treatment. And because of that, there's much less overlap of the radiation with in this case, the rectum and also the bladder, as you can see here. So a lot less radiation dose to those organs nearby. So how are we able to deliver this SABER treatment safely to the prostate gland? And as I alluded before, we use multiple different technologies are exploited in order to allow for delivery of this treatment. And I'm going to go through some of those to you in a bit of detail. And so the first thing is imaging. When we do the SABER treatment these days, we use more advanced imaging. On the left here, this is a CT scan, a CAT scan of the prostate gland here in the middle. You can see the rectum here. In general, or as far as radiation treatment has been going on in the last sort of 20, 30 years, our radiation treatments have generally been planned using CAT scan technology, because if we want to deliver a radiation treatment to the prostate, we need to be able to see it. And so classically, we've used CAT scans to do this. But if you look at that CAT scan, that image on the left, a lot of it just looks like a big gray blob. You can't, this whole big gray blob, it doesn't give us much anatomic detail to the prostate gland. And so nowadays with SABER, we've kind of moved beyond just using the CAT scan to plan our treatments. And so we use other more advanced modes of imaging. So in the middle here, you can see there's a MRI scan. On the right side here, there's what's called a PET scan. And we use these kinds of imaging to better identify and delineate the prostate gland as a target for radiation treatment. And you can see, if you look in the middle with the MRI, you can see the anatomic detail of the prostate much more clearly than you can this sort of gray blob you see on the CT scan. And on the PET scan here, you can see it actually shows you where the actual cancer is with this gold red colored area there as well. So by using these kinds of imaging to plan radiation treatment, we're able to much more accurately define the area that we want to treat, which is invariably smaller. And if we have a smaller target, then we can spare some of those organs nearby better. So more advanced imaging is one thing. The second thing is we use more advanced radiation planning technology, and I won't go into too much detail here today on this, but nowadays, the radiation planning is much more complicated than it used to be before. And nowadays we have a radiation machine that's continuously rotating around the patient. The shape of the beam is continually changing as it delivers the radiation, and the end result is we're able to put the radiation dose where we want it and minimize the radiation dose where we don't want it, so that it's more focused and conformed to the prostate gland itself. The other thing is targeting. So for SABER, we need to make sure that we're hitting the target very accurately, so that we can use those narrow safety margins. And so to achieve that, one way, there's many ways to do this. The way we do it here in Victoria is we put little tiny gold seeds in the prostate gland. So if somebody wants to pursue SABER, the first step before they start treatment is they come in for a procedure that's a little bit like a prostate biopsy. It takes about 15 minutes. And just under our local anesthetic. And I use needles to put these 3 tiny little gold seeds, these little white things that you can see here, into the prostate gland. And the reason we do that is that way when we have someone set up on the radiation treatment table, the radiation machine can see the seeds. That's what this picture is. And so when the person's on the table, we take a picture, it can see the seeds, and the machine knows where the seeds are supposed to be. So if the patient isn't in the right place, if they're off by a few millimeters or something like that, the radiation machine can see that because the seeds aren't where they're supposed to be. And then our fancy robotic radiation table is able to automatically move the patient and adjust the angle of the table to get the seeds where they're supposed to be that day, and therefore get the prostate where it's supposed to be that day. So this is allowing us to target the radiation more accurately to make sure that we know the person's in the right place. So the prostate is where the radiation is going to be delivered. Then the next step is our radiation machines nowadays, actually, they're not just radiation machines, they're also imagers. Our radiation machines can also take pictures, in this case, CAT scans. So once the patient has now been moved based on those seeds to get them in the right place, our radiation machine, before delivering the treatment, can do a CAT scan, take a quick picture, a nice picture. And this confirms that the prostate and the seeds are where they're supposed to be and are accurately targeted. And also confirms that there's not excessive amounts of bladder or excessive amounts of bowel that will receive a high radiation dose. And if it looks like there is, we can adjust the position to make sure that doesn't happen. And then this is actually quite new. So now the treatment starts. We have the patient set up on the table in the right place. The radiation machine starts to rotate around the patient, delivering its treatment. The thing is, it can take, as I mentioned, it can take a few minutes for the radiation beam to deliver the treatment. And during that time, just because, I had the patient on the right place on the table at the beginning, but while the beam is on, the prostate can still move during that time. And that's not optimal. So we now have a new piece of technology that while the radiation treatment is being delivered, it's continuously taking pictures at the same time. And so that's what these are here. These are just a couple of examples of the pictures. As the treatment is being delivered, it's continually taking pictures, basically monitoring where the prostate gland is. And so in this picture here, you can see the seeds are within these little green circles. That means the prostate is where it should be. As it's delivering it and keeping track, if the seeds move outside of the green circles, everything turns red, the radiation machine stops. And that's because the prostate gland is now moved outside of where the radiation beam is delivering. So it detects that the person is moved or the gland is moved, the radiation machine stops, and then we reset it. We use the previous slides technologies to put the patient back where they're supposed to be. So if at any point during the delivery, we're not hitting the target, our machine knows it right away, stops the radiation delivery, puts them back where they're supposed to be. And this is actually a relatively new technology we have called triggered imaging, and was actually, we're quite grateful to the BC Cancer Foundation for providing the funds that we could obtain this technology. So now the radiation treatment's being delivered, we're tracking the prostate the whole time to make sure that we're hitting the target the entire time. The last thing that helps us to get away with delivering these big doses with SABER technology is a product called Space OAR Hydrogel. And what this is, Space OAR Hydrogel is a product that can be injected in between the prostate gland and the bowel, the rectum. And so you see here, this is without the gel. You see the prostate's here and the rectum's here, and this pink dashed line, that's the high dose of radiation. A little bit of the rectum is getting a lot of radiation. If we put this gel in, it moves the prostate gland out of the way, and so now that high dose of radiation is completely missing the bowel, the rectum. And so people get less side effects from radiation treatment if they have this gel in place. And actually, to thank the Prostate Center for this. The Prostate Center actually helped us to pilot this program that we have here for using this hydrogel in the treatment for prostate cancer. And actually, BC Cancer has the largest program using this product in the country, which has been proven to reduce side effects and improve quality of life. So by pulling together all these different technologies for imaging the gland and for making sure the patient's where they should be, tracking the gland, moving the rectum out of the way, we pull these things all together. At the end of the day, what this does is gives us a very, very focused, accurate radiation treatment where we give much less radiation dose to the rectum and to the bowel than our regular radiation treatments. And because of that, we're able to get away with reducing our number of treatments from 20 to 38 treatments to down to 5 treatments, which is much more convenient for people. We think that the tumor cell kill from these bigger doses of radiation are more effective, and we think that it leads to less damage to the normal organs nearby, so people have less side effects in the long run and less a better quality of life. So the last bit I wanted to speak about is, I've told you what the technology is, but how does it work? How does it compare to the other treatments that we have? And that's where the one caveat comes in. This is a relatively new technology. The other treatments that we talked about, surgery, regular radiation treatments, brachytherapy, we've been doing those treatments for 30, 40 years or longer. This prostate stereotactic treatment, SABER, hasn't been around that long. I mean, the lifespan of this treatment sort of worldwide is more in the 8 to 10 year range, and so we don't have as much data accumulated yet to tell us everything that we need to know about this treatment. And there does remain a lot that there's a lot that we do know about it, but there also remains a lot that we don't know about it. It is a work in progress. I mentioned before that the goal would be to try and find a treatment that is as convenient and effective as, say, brachytherapy or surgery, but as well tolerated, non-invasive as external treatments. That's certainly the goal. But whether we've achieved that goal yet or not, I don't know. It is a work in progress. These things this technology is evolving over time. Because there are things that we don't yet know about this technology in BC, we've agreed that for men who want this treatment, prostate SABER, we put them on what's called a registry. And what a registry is, it's a system whereby we can keep a closer eye on people. And so we kind of keep a closer eye on them, keep an eye on the side effects a bit closer, email them forms to fill out to let us know how they're doing in terms of side effects. And the goal here is so that we can collect that long-term data that we don't quite have with this treatment compared to some of the older treatments. But there are a few things we know. One thing we do know for sure is we do know that the short-term and the long-term side effects of prostate SABER are quite favorable compared to those of regular external treatments. And we know this from actually part of this comes from a study done, pilot in Victoria, done in BC, called the ASSERT study, where we compared SABER with regular radiation treatments. And if you look at this table here, this just shows how often people get side effects. The UHF stands for SABER, MHF is regular radiation treatment. If we look at the percentages of serious side effects, the percentage of serious side effects with the bladder is very low, and the percentage of serious side effects with the bowels is very low. And if we look at the rates of sort of mild to moderate side effects, again, comparable to the regular radiation treatments and low across the board. And this one just shows the time course, the dashed line, the time course of the side effects with the bladder. The dashed line is the SABER, and the blue line is the regular radiation treatments. Definitely compares favorably with the regular radiation treatments in terms of the side effects. And when we look at the long-term side effects, again, it compares favorably. These three graphs show the percentage of men who are free of long-term side effects. So if we look at serious side effects, the blue line is the SABER. The green line is the SABER. The blue is regular treatment. The vast majority, more than 95% of men, are free of long-term side effects, serious long-term side effects. When we look at sort of mild to moderate bladder side effects, the green line, again, 90% of people are free of mild to moderate side effects. And again, with the bowel, the vast majority of men are free of mild to moderate side effects. So again, compares favorably to the regular radiation treatments. And then lastly, when we look at quality of life, when we look at leakiness, urinary incontinence, the light line here is SABER, the darker line is the regular radiation treatments. We see that we have actually a substantially lower rate of leakiness and incontinence with the SABER 1 year after treatment, and with the bowels 5 years after treatment. Again, we have substantially better bowel quality of life with the SABER than the regular radiation treatment. And this is all data that was done with a BC-wide study. So we know that the long-term and short-term side effects are at least as good, if not better, than regular radiation treatments. We also know that the long-term side effects of SABER compare favorably to surgery. And again, this is a bit of a busy slide, but this was a study done in the UK where they randomly assigned men to have surgery or SABER for their prostate cancer. And when they looked 2 years after the treatments, 47% of the men who had surgery were having to use or had some degree of leakiness requiring the use of urinary pads, at least one pad per day. Whereas with the SABER, it was only 4.5%. So, a very, very big difference in urinary incontinence between surgery and SABER. The SABER compared to surgery in this study did have slightly worse long-term quality of life with the bowel. They give what's called a bowel score. If your bowel score is 100, that means your treatment didn't affect your bowels at all. And surgery got a bowel score of 97, so it barely affected the bowels. Whereas with radiation, it was a little bit lower at 88%. So it did have a little bit more effect on bowel bother. But when we look at how common bowel problems were with SABER over on the green column, the vast majority, the vast majority of people who did have bowel problems from SABER were very minor problems. So it compares favorably in terms of side effects to regular radiation treatment, compares favorably to surgery for regular radiation treatment. That's all great. What's the disease control like? Are we able to keep the cancer away with this technology? And this is where we have some elements that we don't know yet because the treatment is so new. What we do know is, and this is actually hot off the press, the study on the right side there just came out yesterday. And so I had to actually revamp my slides. We do know that the disease control with this technology is at least as effective as the regular conventional radiation treatment. And these are just slides from two studies. The slide on the left was an older study of SABER that used not quite as good technology as we have now. And even then, we see the disease control was about 85% at 5 years. So the vast majority of people free of disease at 5 years. The newer study that was done there called PACE-B that just came out yesterday, they actually reported 96% of patients being free of disease 5 years after treatment, which is excellent. Very excellent results. What we don't know is how SABER compares to the standard radiation treatment in the longer time period. Certainly it's as good as, at least as good within the first 5 years afterwards, but what happens in the 5 to 10 year period or the 15-year period afterwards? That's where we don't know yet because the technology hasn't been around that long for us to have those have that data. But if you do look at the data that I showed you from that study that just came out yesterday, if you look at this, the blue is the SABER and the red is, or the orange is the regular radiation treatment. You kind of get the impression that with time these graphs are starting to separate a little bit, and so you do wonder if I'd be interested to see when we go out to say 10 years or 15 years whether there may be a difference between the two in terms of disease control. We'll have to wait to find out. The other thing is we don't know yet. This is where we get into the realm of things that we don't know, but we think. We think that SABER is at least as effective as brachytherapy, but that remains to be proven. And these are just two studies that have looked at that. This is a study that compared it with the seed type brachytherapy, where the SABER was at least as good, if not better, and another one that compared it to the non-seed type brachytherapy. Again, very similar rates of disease control, but those studies are small and we haven't got definitive data on it. And then lastly, for men with I remember I mentioned that risk groups, low, medium, and high. For men with the very high risk disease, we think the SABER seems to be very effective, but the large studies of men with this kind of higher risk disease are still pending and we don't know. But this is one of the early kind of studies looking at it. And actually this graph shows two studies where the control rates for the very high risk disease ranges somewhere from 100% to 85% at 4 or 5 years after. So it's very encouraging that the disease control for the very high risk cancers may be very good with SABER, but that's where we need a bit more work. And that's why we come to the outcome results of some of the larger, more definitive trials and studies for prostate SABER, and compared to say other treatments are still pending. And the long-term data will take us a bit of time to get the data on how well it performs at 10 years, 15 years, 20 years after treatment. So lastly, I just wanted to close off with a few of the new directions we're going with SABER. One is for men whose cancer comes back. Sometimes, if someone has treatment for a cancer with, say, radiation treatment or brachytherapy or something like that, and the cancer comes back, but only comes back in the prostate gland and nowhere else, that's a very difficult problem to deal with. Because someone who's had radiation treatment to the prostate gland, whether it's brachytherapy or regular radiation treatment, the only reasonable option we have right now would be to have surgery to try and salvage that if the cancers come back in the gland. The problem is surgery after someone's had radiation treatment can be very difficult because the radiation causes a lot of scar tissue to form around the prostate. And so people who have surgery after previous radiation treatment are unfortunately subject to very high rates of side effects like incontinence. Sometimes you can use brachytherapy, but again, the side effects can be problematic. And even when you do some of these kind of salvage treatments, the control rates aren't great. The chances of cure are about 50%. But there is some data coming out now that you can use SABER for this. And this is just a study that looked at it, where they used SABER to focus specifically on the area where the cancer has come back in the gland after previous radiation treatments. And they found they were able to achieve this treatment with minimal long-term side effects and really encouraging disease control rates at about 80%. So this is something where it could be really useful if men's cancer comes back. The other thing we're looking at is, are we able to give the SABER differently to have even less side effects and better control? And so what this looks at is new strategies of delivering SABER. So instead of, maybe we don't have to give a high dose of radiation to the whole prostate gland, maybe we can give a fairly low or moderate amount of dose of radiation to the whole prostate gland, and then just give the high dose, the extra dose, to the spot where the actual cancer is. And by doing that, we may be able to spare the organs nearby better and have less side effects and better control. And preliminary data of this stuff looks great, but it's going to take time for this to come to fruition. And then finally, this is the one that we want to do in Victoria, our new direction with Prostate SABER. We have put forward a study that we call the ADAPT 25 trial. And this is a study that we want to open in 2024. And we want to use all these advanced technologies that I talked to you about today. But on top of it, we want to add the artificial intelligence. Humans can guide radiation treatments really well, but computers with artificial intelligence, we think, are able to actually guide that treatment even better. And so we have an artificial intelligence algorithm that can help us to target and track and monitor the prostate gland while we're delivering the treatments. And we want to combine that with all the other technologies that I've talked to you about before to see if we're able to get the SABER treatments down even further. So instead of men having to come in for 5 treatments, we are pretty confident that we can deliver this treatment in just 2 treatments. So a man just comes in for 2 quick visits, has the treatments, and goes home. And we think that we can deliver this treatment with comparable side effects and if not better, and perhaps with comparable or better disease control. So this is the new study. I just today actually fired off a grant proposal for some additional funding to do this study. And so the plan is to open the study into mid to late 2024 at the BC Cancer Center, BC Cancer Victoria, and BC Cancer in Surrey. So that's something we're really excited about, using artificial intelligence to help guide our treatments and help men to get in and out, as quickly as possible. Because at the end of the day, our goal is to try and, a goal that we can probably never reach is to try and devise a treatment ideally that would have, 100% cure rate, 0% toxicity, and get someone out in and out of the cancer clinic as quickly as possible. Obviously, we can never achieve that goal, but as close as we can get to that goal is what we strive to achieve. So, in conclusion, Prostate SABER is an emerging option for prostate cancer that is very convenient for patients and is associated with a really favorable side effect profile. We know that the disease control, at least at 5 years, is as effective as conventional treatments, but the long-term effectiveness is still needs to be determined. But with optimal doses and techniques, I personally believe that SABER will end up being as effective as surgery or brachytherapy, but the definitive data is pending. So that's all I had to say. Do you have any questions about that?
Yeah,